Hey there, everybody. Let's go through the pathology of hemodynamic disorders. So, the definition of anasarca is severe and generalized edema. It occurs throughout the entire body from the head to the extremities. And they are mostly caused by Turner syndrome, the Rh incompatibility with mother and child, alpha thalassemia, and sickle cell disease or sickle cell anemia. So, just as a reminder, left heart failure is going to present with dyspnea. There is going to be coughing, crackles, wheezes, but this is more of like a pulmonary problem, right? In right-sided heart failure, it is really defined by pitting edema, especially in the legs. So when the kidney fails, that's when you get the anasarca. It can also occur from mastectomy because the lymph node in the axilla would be removed. And in chronic diseases, there's going to be fibrosis, so scar tissue is going to be laid down, and angiogenesis. Filariasis, sorry, never can pronounce these things, is due to a couple parasitic infections. You don't really have to know exact parasites, but this is going to be due to an infection. It's called Proteus syndrome, and it is basically chronic lymphangitis, so inflammation of the lymphatics. It's characterized by edema, hypertrophy and fibrosis of the skin, and subcutaneous tissue, and it's also known as elephantiasis, and there is going to be keratinization of the skin. It's going to look very tree-like, bark-like. So pulmonary edema occurs when there's fluid and it backs up into the left heart, because remember, there is right to left pumping or blood flow from the heart right to left, and then if the path fails, it comes back to the left heart. The capillaries can rupture. That's why there is hemosiderin accumulation in the cells and bloody sputum. And these are also known as heart failure cells. Remember this term. In acute pulmonary edema, the red blood cells are going to be found in the alveolar spaces, and they're also, and then in chronic pulmonary edema, there's going to be the heart failure cells. So these are not quite, this is not quite problematic yet. This is when you need to be considering bronchial dilators and whatnot, because with the hemosiderin, that's an indication that there has been fibrosis. Okay, so cerebral edema, of course, is bad because it's hydrocephalate, so there's going to be CNS disturbances. In MRIs, you can see that the sulci are narrowed and the gyri are going to be dilated. It can be due to abscesses, tumors, or injury, and they present with generalized hypertension. But the more important thing is they're going to have CNS disturbances. So in the liver, usually occurs because of cardiac failure, and then there's going to be damming of the blood in the internal vena cava. So blood isn't going to be able to be pumped correctly. It's going to back up, and then the central vein and the sinusoids of the liver is going to be distended. And the pitting edema is going to occur thanks to the congestion. The hepatocytes closest to the central vein, here we go, is going to be affected first. So in the portal triad, these are going to be affected basically last. Here you go. Here's the central venule, so the cells around here would be affected first. In severe cases, the pigments will accumulate, the bile will accumulate, and it's called nutmeg liver. The causes: alcohol abuse, hepatitis infection, and right heart failure because of the damming of the blood, remember, and the way the blood pumps right to left. So there isn't going to be a venous return correctly into the heart, and it's going to fail. Okay, so thrombosis. We want to diagnose them using the Virchow triad. So this is it: stasis of the blood, hypercoagulability, and the vessel wall injury. And these all like connects because when this occurs, the injury occurs, all of the platelets are going to release like von Willebrand's factor, factor 8 because it's an extrinsic path. Factor 7 because it's extrinsic path, and then it's going to lead to the stasis. First affected endothelial cell. The vessel wall injury, if it's within, it's going to be the intrinsic path, not the extrinsic path. This will only occur if the extrinsic path will only occur if the external injury occurs. So the red thrombi is going to be due to the low pressure and the slow blood flow, thanks to the stasis. And all the venous blood is going to lead into the lung. So this person is also going to present with dyspnea. These are the strongest procoagulants, got to be aware of. So LPS, endotoxin, mucus, that would be thanks to the adenocarcinoma, amniotic fluid, and M3 leukemia. Why is amniotic fluid a procoagulant? It's because of an immune system reaction. So this isn't for the baby, this is for the mother. Okay, so pulmonary thromboembolism, once again, dyspnea, first sign. Then it's going to be tachypnea, a sudden pleuritic chest pain. So there's going to be pain with inhalation. This person is going to breathe very shallowly. So they're going to try to minimize the stretch on the pleura. Jugular venous distension is going to occur. Kalsman sign will be occurring. This is a type of breathing. It's when you the person will breathe and kind of hitch their breath because of the pain. And there's going to be pitting edema, of course, in the legs. So in a massive pulmonary edema, massive saddle emboli, here it is, there's not going to be any pain. The person will die suddenly because of the obstructive shock with the circulatory collapse. So there's not going to be any blood going to the brain, to the lungs, or to the heart. VQ mismatch is going to occur, of course, because there's going to be wasted ventilation. Air is going to come into the lungs, but is not going to be able to perfuse. There is going to be the pulmonary vasoconstriction, trying to shunt the blood to the more, the more healthy, the less damaged lung tissue. And then the bronchial spasm is just due to the different kind of receptors. So when prostaglandin is going to be released, or histamine is going to release. Remember, the lungs are just kind of its own special case. So when everything else dilates, this thing will constrict. In a paradoxal embolus, that only really occurs if there is a ductus arteriosus, because that, or some kind of anastomosis. So it's more of a congenital thing, because the clot will pass from the vein to the artery. Fat emboli usually occur due to a fracture of the long bones, in particular the femur. So it takes a while to show up. First, it shows up or it presents as a pulmonary insufficiency. So you're going to have problems breathing and perfusion. There's going to be neurologic symptoms from the hypoxia, anemia, thanks to all of the blood cells now, or the immature blood cells without special tissue-specific antigens on it. So the immune system's not going to recognize that, hey, these are my cells. So they're just going to attack, causing the anemia. Also, it's a hemorrhage, especially if it's a big break like this. The thrombocytopenia is going to present as the petechiae rash when the platelets adhere to the fat, and that usually occurs in the axilla and the chest wall. Okay, air embolism are gas bubbles in the vessels. So this is the bends, so decompression sickness. And more importantly for us, the bends is pretty common, but in a medical setting, it's the incorrect administration of the IV lines or injections. That's why you do have to be very careful to flick the syringe to get rid of any of air bubbles, because this can get trapped and then cause an air embolism. Okay, amniotic fluid embolism, once again, it is a type 4 hypersensitivity reaction when the amniotic fluids will enter the maternal circulation. It presents with first rapid respiratory failure, and then there's the hemorrhagic phase. It's going to be disseminated intracellular, not collapse, but DIC. It's going to be extensive lysis of the red blood cell, because this reaction is going to be systemic, right? So what do you have to be worried about? Hypotension, because of the cytokines released. They're going to dilate everything. Dyspnea, because of the thanks to this, are all the vessels dilating. Lungs, remember I said, are just the odd ones, so they're going to constrict. There's going to be pulmonary edema, thanks to the lungs acting up, and then cardiac collapse. Okay, so hemostasis, you should know, intrinsic, extrinsic path. Intrinsic are all the numbers except for factor 7. Factor 7 is the only extrinsic path. They are going to release procoagulants, especially von Willebrand. Those are released by the endothelial cells. And the endothelial cells will also secrete endothelium, which is what the platelets would adhere to. And a muscle spasm to constrict the veins. And thromboxane 2 is going to promote the platelet aggregation and the vasoconstriction. Extrinsic pathway is pretty fast. Intrinsic is slow, but this one is more permanent. Okay, bleeding time depends on how many platelets you have and if they work. Normally in a healthy person, about 3 to 7 minutes. First, fibrin has to stabilize the clot, and then factor 13 comes in, and that stabilizes fibrin. Red thrombi occurs when red blood cells get trapped, and Zahn lines will form mostly in the heart, but that could form in other places. And this is going to be made out of layers of fibrins and red blood cells, and this is particularly important to diagnose myocardial infarctions, old myocardial infarctions. Okay, hemostasis, let's go through the steps. First is going to be the vasoconstriction. Thromboxane 2 is going to be released along with these other procoagulant factors, serotonin, epinephrine, and fibrinogen. And these all depend on ADP dephosphatase. The primary plug is going to be made. It's going to be weak. It's going to be unstable. And then during the actual coagulation phase, the second definitive plug is going to form. It forms faster and it forms stronger than the primary plug. After the basement membrane of the endothelial layer has been replaced, the clot will be lysed in fibrinolysis, and then if needed, if the basement membrane is intact, normal cells will kind of fill in the hole and regenerate the tissue. If the hole is too big, then it's going to be repair, and collagen is going to replace the endothelial cells instead. Okay, so the coagulation cascade is a cascade because each step is stronger than the preceding step, so it's more of a hop, 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 and that allows time and place for the regulation, and it's not an all or none kind of cascade because it's rate limiting. There are places that it can be regulated. So unless the platelets are activated, this is the requirement. There's no coagulation. So platelet adhere thanks to von Willebrand factor and GP1B. Activated platelets will release von Willebrand factor and ADP, and those will attract the platelets. Like more platelets will come. GP2B3A receptor is going to be expressed on the platelet, and it activates thromboxane 2, which promotes more platelets to come in, and that also promotes vasoconstriction and bronchoconstriction. The platelets will connect thanks to the GP2B3A, and fibrinogen is going to link it, and this is going to be the second plug. So thanks to, like, these are going to link the platelets together. Von Willebrand is going to link it to the subendothelial matrix, and it's going to bind to the collagen. Okay, so diseases. Bernard-Soulier syndrome, it's going to be diagnosed by increased bleeding time. GP1B is going to be mutated. In Glanzmann thrombocythemia, GP2B2A is going to be mutated. And to treat both of them, you transfuse the platelets. This is a problem with the platelets. However, in von Willebrand's disease, you just transfuse plasma because the von Willebrand factor is found only in the plasma, or not just in the plasma, but it's found in the platelets and the plasma. But we don't want to give those patients more platelets because you can actually form like clots, like unnecessary clots. Their platelet count is fine. They just don't have something that links it to the endothelial collagen. So, like in this picture, let's see it here, Glanzmann thrombocythemia. So there's going to be a problem with linking the platelets together. A deficiency in Bernard-Soulier syndrome, there's going to be a problem with actual like receptor on the platelets. That's why we want more platelets. We want fresh platelets. Von Willebrand is going to be a problem with the endothelial layer. Okay, so aspirin will inhibit platelet aggregation, and at the injury, platelets will like come, bind, and they swell, and then they become something called a pseudopod. Let's see, we already went through this. Once attached, the platelets will contract and release the granules, activating all of the platelets. ADP is going to convert GP2B3A to its active form. Calcium is going to be released, releasing the thromboxane 2. That constricts the vessels, of course. Fibrinogen links everything together. And then when the platelets all fuse, this is an irreversible, this is going to be irreversible. Like the clot has formed. This is the secondary clot. It's now there until the endothelium has been repaired. Okay, so intrinsic depends on the factor in the blood. That's why it's intrinsic. It's more efficient. If the injury is within the vessel and there's no leakage, only the intrinsic path will be activated. So extrinsic is going to depend on the factors outside of the tissue. So it's going to be the outside of the vessel being, the outside of the vessel is going to be injured. So shorter, faster, less efficient, but it's a trade-off. Okay, so in intrinsic, this is going to be characterized by blood in the muscles and the joints. It's very painful. Extrinsic, there's going to be hemostasis in the brain, the lung, the placenta, heart, and uterus. Both of them are dangerous. Both of them are bad. Okay, so in the intrinsic path, once again, injury within the vessel, factor 12 is going to be activated, and it's going to bind to the phospholipid surface. And then the cascade goes from 11, 9, 8, plus the von Willebrand factor. These two have to be together. And those will activate factor 10. And then lastly, factor 13 will come in, cross-link the fibrin. And then fibrin, thrombin, makes the actual fibrin. And what do we look for? We look for the prothrombin time. And you use heparin to treat this if there is a problem with clotting. So in the extrinsic there's going to be factor 7, then factor 10 plus the calcium plus a platelet, and then factor 5. Prothrombin, once again, complex, and then the thrombin will form. So the prothrombin complex is going to be made of factor 10, the calcium, platelets, and the factor V. And then tissue factor, thromboplastin, and the platelet will become in contact with factor 7. That kind of like starts the entire cascade. So we look for tissue factor in the blood, prothrombin time, or not prothrombin time. We're going to look for, partial. No, we're going to look for prothrombin time. I was right. In the intrinsic pathway, you look for partial thromboplastin time. Then you're going to treat them with warfarin or Coumadin. So in an antiphospholipid syndrome, there's going to be a problem with the phospholipids that prevent the coagulation. So it's in patients that have like lupus anticoagulant syndrome, and in systemic lupus erythematosus, there's going to be antibodies against, I said everything, but it's actually nucleic DNA. So that's nucleic acids in DNA. So that means that it really is going to be antibodies against everything. We'll cover that more in like in a different like lecture, but just know that it presents as like a malar rash for now. Anyway, so this you have to kind of keep in mind: is it systemic lupus erythematosus or is it syphilis? Because like on a test, somebody with lupus could, on a syphilis test, somebody with lupus can be positive because the antibodies against the phospholipids are going to be, the phospholipids against syphilis is going to be too similar. So the antibodies will react against like normal human cells. So for syphilis, there's more of like specific tests. Use VDRL or RPR test or the Lewis test, but like just kind of keep that in mind. Okay, DIC. There is going to be caused by sepsis, malignancy, trauma, intravascular hemolysis. So that's the big important one. You're going to be losing blood, and there's going to be a big infection, a systemic infection. So in the serum, the D dimer is going to be increased because all the procoagulants have been used up. And in order to dissolve the thrombi, you need plasmin or urokinase or streptokinase. So we give them heparin to prevent the thrombi, right? So, okay, in sepsis, what happens? There's going to be depression of the inhibitory system. There's going to be inhibition of fibrinolysis. So it's all going to form with a lot of fibrin deposition, and then thrombosis will occur. And thanks to all of the coagulant making the fibrin, there's going to be depletion of the clotting factors and increased bleeding. So usually it's caused by gram-positive or negative organisms. It's going to be malaria, hemorrhagic fevers, and thrombosis could, even if you treat them like kind of successfully, you have to like know that the thrombi could be in like a small capillaries, and the one that you need to be really careful about is the kidney. So you also have to be careful if the patient is pregnant, because there can be like very profuse bleeding. Okay, so endocarditis is going to be presenting with thrombi in the heart that is not attached to the endocardium. So what's it going to attach to? Usually a valve. So there's no actual inflammation inside the heart. Vegetation grows when there's it's called it's just called vegetation because it grows like vegetation, but it means an infection, and it's going to occur in Lehmann-Sachs endocarditis. Usually that's found in the upper surface of the endocardium, and bacteria is going to cause the valve infection. Non-bacterial, it could be a stroke, but that's not going to be vegetation. That's going to be thrombi. What can bring on all of the infections and the strokes? Could be improper dental care. Head is pretty close to the chest. It can spread. Catheters, like PICC lines, something that inserts into the IJV, or intravenous drugs. Like that'll do it, because the patients will be injecting themselves incorrectly, and they're going to have like many air emboli, and those can lead to like strokes. And so somebody with strep endocarditis, with the vegetation on the leaflets of the valve, there's going to be regurgitation. So if you hear a murmur in a patient and they don't really have hypertension, you should ask them, like, did you ever have rheumatic heart fever in the past? Okay, so bleeding, petechiae are little spots, purpura are going to be larger spots. Basically, that's what it means. Ecchymosis is going to be a large bruise, and hematoma is going to be a collection of blood, so basically a big bruise, deep in the tissue though. So primary hemostasis is going to be asymptomatic. It's usually very superficial. Secondary hemostasis, this is going to be the bruise. It's going to be very painful. In some cases, that can occur like late rebleeding after surgery. So after a trauma, surgeries are considered trauma. The capillaries can be overworked when the body's trying to send too many nutrients and cells to repair the site of trauma. They can be like overworked basically, and then they get dilated, and then they burst, and then you get a big old bruise. So the important ones you got to be careful about is blood in the joints. That's bad. Retroperitoneal and intracranial bleeding, of course, because this can be peritonitis, very hard to treat, and this can be like leading to like cerebral edema, pressure on the brain. Okay, so hemophilia A is going to be a deficiency in factor 8, so there's an intrinsic pathway deficiency. Hemophilia B, also known as Christmas factor, factor 9 is going to be affected. Hemophilia C, Stewart-Prower factor, or factor 10. Parahemophilia, also known as Liedman's disease, I think I'm saying it right, is the most common one. It's going to be a deficiency of factor 5. Afibronogenemia, deficiency of factor 1. Hypoprothrombinemia, deficiency of factor 2. These are rarer. And von Willebrand's disease is going to be, once again, needs a plasma transfusion. The deficiency is the von Willebrand's factor. All of these are going to be problems with bleeding. And, it's not the bleeding that's a problem. These are all problems with clotting. So there's too much bleeding. Oops, I think I missed something. Alrighty, here we go. Factor 5. Oh, Leidens deficiency once again. This one's a little special compared to the other hemophilias because, like I said, it's the most common. There's going to be a resistance to activated protein C. So not just a factor 5 deficiency. It's going to be a resistance to activated protein C. So in oral contraceptives, you have to ask the patient these questions because these are going to be like very, very high indications that this person will form thrombi. Nephrotic syndrome will also cause like some kind of hemophilia because you're losing antithrombin 3 and protein C, so you're losing the coagulation factors. Okay, infarction leads to ischemic necrosis. Well, it causes this. It doesn't lead to it. It causes this. It's thrombotic or embolytic events. So that's due to the single venous return. The heart only, has everything basically going in, from the vena cava, right? So in a hemorrhagic infarction, that's when the vessels the coronary vessels are going to rupture, and instead of ischemia, it's going to be hemorrhage, right? Blood is still not going where it needs to go, but there's no blockage. It can also be caused by sepsis, and these are the factors affecting the hemostasis. Once again, coagulation pathway, prothrombotic, antithrombotic, so Infarction, you want to be giving them the antithrombotics. Okay, so thank you for your attention. It's been a long video, but yeah, so thank you for your attention. Good luck studying.